Good afternoon, everyone. At the outset, I would really thank the scientific committee of AIOC and APO and the chief instructor for giving me the opportunity to be here. Therapeutic penetrating keratoplasty basically has got different outcomes. So we had observed the outcome of first 100 keratoplasties at our center. As we all know, corneal blindness is an important cause of loss of vision. And as per the NPCB estimates, around 1,20,000 corneal blind persons in India, adding 25 to 30,000 every year. The core study suggests that the infectious keratitis is a very important cause of corneal blindness and a cause of morbidity in Indian population. So one of the landmark studies of South India has recognized corneal ulcer as a silent epidemic in this zone. So progressive corneal ulcers not responding to medications often definitively need the treatment of therapeutic penetrating keratoplasty. The post-operative outcomes in these type of cases have been observed in different studies in relation to infection eradication, the visual acuity achieved, the history of associated trauma or the use of any traditional medications, or a pre-existing scleral involvement, or having coexisting diseases. So we at our place analyzed the clinical outcome of first 100 therapeutic penetrating keratoplasty cases. A retrospective analysis was done for TPKs for non-healing keratitis with or without perforation with a minimum 1 year of follow-up, and we excluded patients with vitreous exudates. Medical records of these patients were done between October 2014 to December 2017, and the primary treatment of these patients were according to the severity of the presentation, and primary microbial evaluation was performed at the time of presentation and was repeated after a week in cases of non-responding ulcers. Initial antimicrobial treatment was modified as per the culture sensitivity report and clinical response to the treatment. Posterior evaluation was done as done routinely in these cases. TPK was performed after the failed initial management in non-responding progressive ulcers, ulcers having desmetocele, or perforated corneal ulcers. The donor cornea utilized in surgery was of therapeutic grade, and the standard average size used was 9 millimeter. Primary lens removal was done in cases where anterior capsule was involved, and donor corneal button was larger than the graft size by 0.5 millimeter and was standardly secured by 10-0 MFN suture. Post-operative medications included antimicrobials, cycloplegic agents, intraocular lowering agents, and lubricating drops. Post-TPK glaucoma was considered as an IOP higher than 21 millimeters of mercury or digitally raised IOP where the IOP couldn't be measured. Success of surgery was measured as a measure of infection eradication and maintenance of the globe integrity. Other factors which were considered were the need of repeat surgery, the IOP control, and graft clarity. Now, these cases of TPK were followed up for a period of 1 year. All the ulcers included in our study were graded as per the classification. 15 cases presented with corneal perforation larger than 3 millimeter in size. 22 cases had desmetocele at the time of presentation, and scleral involvement was seen in 6 of the cases. Primary pathogen could only be detected in 40 of the cases, and rest were microbiologically inconclusive. Now, coming to the distribution of isolated organism in these culture-positive cases, 65% were found to be of fungal origin, most commonly Aspergillus, and 20% bacterial, most commonly Staph aureus, and rest others, 15% were of mixed origin. 10 cases were found to have lens involvement with the primary infection, and removal of lens matter sparing the posterior capsule was done in these cases. In 7 cases, inadvertent removal of lens bag complex occurred, and though anterior vitrectomy was performed in these cases. Coming to the graft clarity, allowing the view of anterior chamber could be maintained only in 26 cases, 15 of which were of bacterial keratitis preoperatively and 5 had fungal pathology preoperatively. Rest 6 of them, the nature of pathogen was not known before the surgery. Now, distribution of organisms in cases of graft infection. Again, the fungus was found to be more predominant, commonly Aspergillus, and bacterial after that, and majority of them were inconclusive microbiologically preoperatively. The earliest onset of infiltrate seen in graft reinfection was 2 days after the surgery, and none of the cases got repeat infection after 3 weeks of surgery, and they were treated with topical and systemic antifungal and antibiotics depending upon the primary pathogen isolated. And in cases where primary pathogen was not known, Topical and systemic antibiotics were the main arm of treatment. Now, regarding to maintenance of globe integrity, anatomical restoration could be done in 96% of cases, and 4 cases ultimately required evisceration despite all measures being taken. Now, repeat TPK, 7 out of 23 cases of reinfection required repeat TPK. 10 out of 47 cases of secondary glaucoma required glaucoma surgery, and 4 cases were eviscerated, as I mentioned earlier, of which 3 had pre-operatively scleral involvement at presentation. So the outcomes, what we could come out is the graft infection rate was 23%, and the success rate as related to anatomical restoration and all. Bacterial was, the patients having bacterial infections pre-operatively were found to be 83.34%, and fungal followed by fungal 76%. With regards to globe integrity, 96% of the cases were salvaged. Coming to graft clarity at the end of 1 year was around 26%. What we could see that it was lesser than other studies, and in fungal cases it was 19%, which was again lesser than other studies. Repeat TPK required in our center was a little higher than the other studies shown, could be possibly due to the late referral coming at the center. Glaucoma surgery was required in 21% of post-TPK glaucomas. So to conclude, I would say that the post-operative successful outcome of these cases can be considered in terms of 2 factors. Either you go by the infection eradication and the maintenance of globe integrity, at least so that you can salvage the eye. Initially, if the graft clarity is not to that extent, at least you can salvage the eye for a sight restoring procedure which can be taken up later. So this had been published, and I think the take-home message is try to salvage maximally by doing a TPK, because there are certain bad-looking eyes also. They behave in a better way when you go ahead with the salvaging procedure. Thank you.